Welcome to my YouTube channel, Pain-Free Partha. And today we are going to talk about nitrous oxide. If you go on to the history, it was prepared by Priestley. As usual, he invented so many gases. He prepared so many gases, Joseph Priestley, including oxygen. So he was the one who prepared nitrous oxide, and Davy, Hill, all these people used it. And then it went off. Then 1844, Carlton again. In 1844, see here, in 1846 or 45, Massachusetts, same hospital, Horace Wells also gave nitrous oxide for a patient with dental extraction. But the patient complained of pain and Horace Wells was termed as a fraud. But in 1846, what happened to William Martin? It was a success. So Davy, Hill and Horace Wells all actually suicide. He was actress Lotto of the 1870s. Nowhere till 2017, nitrous dominated everywhere. This Lotto actresses was imprisoned, I think, because of misusing nitrous oxide. Now we have no ether, we have no chloroform, no cyclopropane, even halothane is gone, but nitrous oxide is there. That is the important significance of its pharmacokinetics and dynamics. You know how it is prepared in 170 to 180 degrees, 240s. Ammonium nitrate, this is ammonium nitrate, breaks down into nitrous oxide and water. And then it is cooled down from 170 to again back. And there are water and acid scrubbers. They remove nitrogen, nitrous oxide, all nitrogen dioxide, all these things to have pure nitrous oxide. Basically, it is from ammonium nitrate. Higher oxides of nitrogen, NO2 is a higher oxide of nitrogen. This is nitrous oxide is called N2O. Higher oxide means NO2. We know nitric oxide is NO. They should be less than 1 part per million. If it is going to be 50 parts per million, we are going to land up in cyanosis, hypotension, pulmonary damage, and even death. I will tell you an experience of a patient with left hysterectomy, long back, 15 years back. We started the tube and are ventilating the patient. Those days there was no mechanical ventilator, so we started ventilating vein circuit with bag and mask. Slowly it became tight and slowly saturation fell down, and we don't know what is the cause. And at last we extubated, surgery got over and extubated, and patient went fine. Almost the saturation, room air saturation was around 89, 90 and all without any cause, and the patient died later. So one more case, the next day, tonsillectomy we did. There it went into pulmonary edema, but the surgery was very short duration. We removed the tube and patient went fine. So all these things put together, we had in mind that we are giving some toxins. So then we diagnosed probably the nitrous oxide was the cause, and we entirely changed the tubings and everything. And after that, for the next 15 years, we are going. This is some other hospital. This is long back. It's a colorless, slightly sweet. Sweet means we can induce babies. That's the advantage. Molecular weight, boiling point. It is stored as a liquid bare vapor below its critical temperature. It is blue coded. MAC of 105. What is this thing? If you want to make 105%, how? The patient will be hypoxic. Blood gas partition coefficient of 0.45 means what? It will go fast in and fast out. That is the meaning of a very low blood gas partition coefficient. Filling ratio is 0.67 means, for example, this cylinder can accommodate 100 liters. Usually 67 liters are inside. That is the meaning of the filling ratio. It evaporates. The liquid evaporates. There is a latent heat used. This latent heat of vaporization is taken from the atmosphere. So the atmosphere becomes cool air. So ice forms. It's an inorganic. Nitrous oxide diffuses more rapidly across alveolar membranous membrane than nitrogen. That is the basis of diffusion, hypoxia, second gas effect, closed cavities. Now you have a pneumothorax, okay? It contains air. It is nitrogen. Air is 79% nitrogen. Now if you are giving nitrous oxide, it's 30 times soluble. So 30 times more nitrous oxide will go in than nitrogen coming out. So the pneumothorax is so will become big. That is the principle of not giving nitrous oxide to any patient with closed cavity surgeries. What is the possible mechanisms? NMDA antagonism, adrenergic, GABA, opioid, all these things are there, but it is not very clear. NMDA is the principal mechanism of action. See here, endorphin, nitrous oxide, this is opioid type. This is GABA type acting on the GABA receptor. What are the plus and minuses of nitrous oxide? It has got no irritant properties. It has got analgesic property. Halothane, isoflurane, sevoflurane, desflurane, xenon has got mild. But all the other inhalation agents have got no analgesic property except the old ether. So ether has got analgesic activity. No other has got pain killing activity. Nitrous oxide has got analgesic activity. It doesn't get metabolized in the body. So don't worry about liver, kidney and all. Minimal adverse effect, maybe mild nausea, vomiting. Have advantages when used with other volatile agents. Low blood solubility, that is what I told, 0.45. Accuracy of administration, we can give 3 liters. What are the advantages in relation to pharmacodynamics? Mild decreased tile volume, increased respiratory rate. Any agent will cause a decreased respiratory response to hypoxia and hypercapnia. What do you mean by that? When a normal person becomes slightly hypoxic, he will start hyperventilating to remove the carbon dioxide and get in the oxygen. This is what is called a normal ventilatory response to hypoxia and hypercarbia. But if you have nitrous or halothane, this will be decreased. Mild myocardial depression, not sensitizing catecholamines, not much of this mild increase in pressures. That's the most important thing. Pulmonary vascular resistance is increased. What's the problem with nitrous oxide? If you ask, PVR is increased. In any patient of other diseases, cardiac diseases, there is something called cardiac grid, heart rate, what happens, blood pressure, what happens, cardiac contractility, what happens, SVR, what happens, PVR, what happens. So these things, for example, if you don't want PVR to rise, we should avoid nitrous oxide. Cardiac grid of a cardiac problem, mitral stenosis, what's the cardiac grid? Mitral regurgitation, what is the cardiac grid? There, when we want to avoid PVR increase, we must cut down nitrous oxide. As all these things have an increased ICP, CB4 and all. CBA for extracorneal surgery, because when there is disruption of normal cerebral, this may be very significant. But actually, what is it invented for? Pain relief. Okay. Now, to understand the value of analgesia, 10 milligram of subcutaneous morphine is equal to 30% nitrous. Then think of our antennas. Opioid receptor is active. That is why naloxone reverses the opioid analgesia of nitrous oxide. Naloxone reverses nitrous oxide analgesia also. That is why they think in terms of opioid part, even though NMDA antagonism is the prime mechanism of action. There is one fellow called Parbrook. He has told 1, 2, 3, and sometimes they call us 1, 2, 3, 4. Moderate analgesia, dissociative and more potent analgesia, and something called analgesic anesthesia. Zone Parbrook has classified nitrous oxide. There's G.D. Parbrook. He has written a book. The book, The Levels of Nitrous Oxide Analgesia. Now, there is also some use called recreational nitrous oxide use. They say is 10%. The most important problem is B12 deficiency, which will come later. It has no effect on NMJ. Halothane, if you give halothane, we can decrease muscle relaxants. We can decrease vecuronium. That is not possible with nitrous oxide. Halothane, isoflurane, sevoflurane, anything you give, we can decrease our micronium. That is not there with nitrous oxide. Now you see the vast use of nitrous oxide. Now your MAC of halothane is 0.9 or 0.7, 0.8. It becomes 0.36 if you add 70% nitrous. Some books say it's around 0.7 to 0.8. See, it's half when you add nitrous oxide. So you need to use less agents. It starts by 30 seconds and 1 minute action comes and also goes. But if you want to completely get eliminated, it will take 30 minutes. 1 minute action comes, cut down 1 or 2 minutes, it goes. That is 0.45 red gas partition coefficient. It can be used in labor. Demand wall 50% used. I will take Entonox later. Maternal side effects, I am again telling nausea, vomiting, dry mouth. So excellent analgesia we can use for fracture reduction. Some dressings, casualty comes, they want dressings. Casualty we can give through the voice machine, oxygen and nitrous oxide 50-50. They will be slightly sedated and some good analgesia will be there. I have already told you 30% is equal to 10%, 10 milligram of morphine. May have a role in the pain of ureteric colic. Think is because any colic opioids are not good. Okay, so then we can give this drug. It can be good for radiological procedures, colonoscopy, dentistry, pediatric dentistry, dental nitrous oxides. What is psychotropic analgesic nitrous oxide? This is fan. Sometimes alcohol, cannabis, nicotine, craving, give nitrous oxide and remove the craving. These are the various indications of nitrous oxide. Now you see when you should not give. Intestinal obstruction because increased intra-abdominal pressure. Intraocular gas, middle ear. That is what I told already. Closed cavities, pneumothorax. When there is air embolism, air is inside, it will become bigger. Decompression sickness, pneumocephalus, air is inside. So all these things are the problems of nitrous oxide. There is increased incidence of nausea and vomiting. That is very important thing. So weak, non-triggering agent of malignant hypoxia. They have told increased risk of wound infections, but I don't know whether it's clinically important. Pancytopenia and megaloblastic anemia, mild depression of bone marrow after 6 hours of exposure may become severe after 24 hours, probably due to nitrous inactivation of B12. That is what is the most important, nitrous B12 problem. Mild nausea, vomiting. These are all the problems with nitrous oxide. Long exposure B12 deficiency and there may be problems. Increased incidence of gestational defects in OT personnel who continuously inhale nitrous. That is the mechanism of action of B12 and our nitrous oxides. Now we all know this is the basic story of this film by Revise about nitrous oxide inhalation. The person laughs at the death point and there is a big fight between the two villains. Now we know preparation. Nitrous oxide is prepared from with 170 degrees from ammonium nitrate and acid water scrubbers are purified. The problem with higher oxides of nitrous is about pulmonary damage and we need to give methylene blue for this. Mechanisms is NMDA antagonisms, opioid agonism and possibly some GABA effect. Properties, everybody knows, fast go, fast out. No solubility. Okay, that is very important in nitrous oxides. Actions, analgesia is main. We can use it for dental, we can use it for small fracture dressings, burns dressings, Entonox, labor analgesia, and in anesthesia. That is the advantage of nitrous. Yes, dangerous. Number one, nausea, vomiting. Number two, B12 deficiency. And if you are getting to be more prolonged exposure, especially OT personnel in pregnancy, there may be an increased chance of fetal problems.